Do we have a pen? So the position is lateral, the surgeon is standing on the heel side, the assistant is on that side, and as Dr. Rajiv explained, your C-arm is on this side, which is obliquely placed. So if this is the table, the C-arm is placed obliquely at an angle of 45 degrees to the table. So when you're bringing the C-arm in, you see the lateral view like this, and you rotate the C-arm in this direction and slightly dorsiflex to take the axial view. And because this is free, now this is fixed here, but your leg is free and you can rotate the leg to take the Broaden's view while the C-arm is lying like this. So in the lateral position, this will be the tendo-Achilles area, and that is the marking of the fibula, and that is the base of the 5th metatarsal, and that is the 4th metatarsal, and this will be the calcaneocubar joint. And here the important structures that you must be aware of is the one artery there, which is the calcaneal branch, lateral calcaneal branch of the peroneal artery, and just in front of that is the sural nerve. So that is the sural nerve, and that is the lateral calcaneal branch. Now, if you see that the incision, if it goes somewhere here and passes on the lateral surface of the calcaneus, then it is likely to injure the end of the calcaneal artery. This is an end artery, and the plantar skin is thick here. So the plantar skin is supplied by a different vessel, and the dorsal skin on the lateral surface of the calcaneus is supplied by this artery. So any incision which crosses like this, will cut off this area of the skin, will become devoid of any circulation, and that is why you have wound healing problems in the extensile approach. If we understand that, then, and we take precautions to protect the lateral calcaneal artery, I don't see why we should have wound healing complications, provided you have delayed the surgery till the wrinkle sign has appeared. The most of the complications of extensile approach are failure to recognize the correct direction of the incision and going in this way, cutting the lateral calcaneal artery. Before I move on to MIS, I will not say anything about it. So your proximal end of the incision is an L-shaped incision, has to go all the way back, not in the center between the tendo-Achilles and the fibula. Your incision, the proximal end has to almost touch the tendo-Achilles there, and it has to go all the way down onto the insertion of the tendo-Achilles on the calcaneus. If I take it like this also, there is a risk that this incision might necrose. And at that junction where you see the junction of the plantar and the dorsal skin, then you rotate in a gentle curve and take the incision distally towards the base of the 4th metatarsal. Here, if you go onto the dorsal skin, it's all right, because here the circulation is not that of a problem. Because your calcaneus is inclined at an angle, there's a calcaneal inclination angle, and if you continue along the junction of the dorsal and the plantar skin in this area, you will end up going plantar to the calcaneocubar joint. So your anterior end of the incision can err a bit towards the dorsal skin side. So do we have a forceps? So we don't have forceps, and possibly we don't have retractors. So I'm going to use something or the other. So hopefully, now this is not to be done. But no hooks, no forceps holding the flap. So I'm trying to go deep. I don't have the proper instrumentation to hold the foam there. In actual situation, I'll use the back of my forceps and not hold the tip of the flap. You start your dissection at the level of the curve and then go deep onto the bone and just lift off this flap from the bone with your forceps. As you lift your forceps up, there is an area of junction you will see between the flap and the bone. So your knife goes and touches that area, and as far as possible subperiosteally, you lift off that flap from the bone. Now when you do that, the calcaneal artery will be in this flap, as well as the sural nerve will be in this flap, and you will not be cutting any of these structures. You continue this dissection without holding the flap at all, unless you reach this area here, which is the peroneal tubercle, but you will not be seeing the peroneal tubercle, obviously. Here you will be seeing a shiny tendon coming into view, that is the peroneal tendon. And your dissection then continues below the peroneal tendons, and your retractor comes into play, and the peroneal tendon is retracted. As you retract the peroneal tendon, in the deeper part of the peroneus sheath is continuous with the calcaneofibular ligament, so you will dissect that off the bone, and with that the tendons will be retracted with the flap. Now the first step after this is to expose is to put the K wires for the retractors. So we'll put the first wire, and the first wire goes into the cuboid. That is an angle where the peroneal tendons are prone to injure, because they curve, the peroneus longus curves around the cuboid. So once you are making way for this, once you are dissecting this part of the flap, you have to be doubly sure that the tendon has been retracted, and your wire goes under the tendon and then lifts off the tendon, so that the wire is retracting the flap, the tendons with the flap. Then we put a second K wire, which goes into the anterior to the neck of the talus. Obviously you do not expose, here the bone is seen, but you have not exposed anything in this area, so it is just by feeling the fibula, sliding just anterior to the fibula, but just by the feel of it, and you put this second K wire and then bend it with the drill itself. And then we are not going to put a third wire, but if you want, you can put a third wire into the posterior tip of the fibula, or maybe into the back of the talus there, just posterior to the fibula. So that exposes your lateral surface as well as the subtalar joint. Now, at this point, if you want to look inside, you have a bump in place here. That bump is moved onto the leg, the heel is now free. And if you do this maneuver on the table, you see directly into the subtalar joint. There's a lot of clot there. Need to remove that clot, wash it out to see the joint surface. I'm going to take out these structures which are here in the bone model, are meant only to hold the bone fragments in place. So we don't have a forceps, so I'm going to just cut off these tags of tissue which are here just to hold the bone model. The anatomy generally is that there is a lateral wall blowout, which means the lateral wall of the calcaneus is actually separate fragment, this one. So here the fragments are very well in place, very nice to fix them. But in real situations, you have everything impacted and displaced. So the lateral wall is here. The lateral wall is burst out and lying lateral. And the facet that you see inside, are you able to see there? I think idhar se aana beta. We are not able to see any. Yeah. मुझे लगा सब दिख रहा है. Anyway, सब लोग हंस रहे थे. Pradeep आएगा. So what we did was the lateral wall blowout was here. I'm sorry. So the lateral wall blowout is on the top, like this, which is obstructing your view to the facet there. So the lateral wall has to be taken out, and then you will be able to see the fracture line there. Either so. So you see, this is the general configuration. This is a general configuration. The medial wall, the medial fracture line is in place with the stable sustentacular fragment, and the lateral facet is depressed, which was covered by the lateral wall. Having removed the lateral wall, you are now able to see, by inverting the heel, you are now able to see the medial fracture line, and that is the fragment which has to be lifted. That is the next step. Now you have visualized the fracture. The next step is to first align the tuberosity. So we will take a Shan's pin on a drill. Here in this situation, you can do it with a stout Steinmann pin, Most of the times what I have found is that if you use a Steinmann pins, the moment you try to manipulate it, it becomes loose and you don't have a purchase in the bone. So I have now started to use Shan's pin, 3.5 millimeter Shan's pin, and I don't use a drill bit, I directly drill it. Now this has to be done looking at the axial view. And you remember that the tuberosity is lying in varus, which means your angle of the Steinmann pin has to be in the axis of the tuberosity. Initially you don't have to look at the sustentacular fragment because it is angled about 60 degrees. So unless your hand goes down towards the floor, you're not in the right axis. And then if you drill parallel to the floor and you lift, you won't have the maneuverability to lift up your hand. So you enter in the axis, in the lateral view, enter in the axis of the tuberosity fragment. In the axial view, when you have reached the reverse कैसे? When you have reached the fracture in the axial view, then you have to manipulate the tuberosity in two maneuvers. One is bringing the tuberosity down, because of the impaction the tuberosity is also tilted and the inclination angle is less. So you have to bring the tuberosity down with this maneuver and lift up your hand to take it out of varus. And in this position, you can replace your drill bit and use a T handle here. Can we remove it? So you have not still entered the sustentacular fragment. So you have reached up to the fracture where in the axial view now you are seeing that the Steinmann pin is about to reach the sustentacular fragment. So your assistant holds this down and correcting the varus, and you can then put one Steinmann pin or two Steinmann pins or a couple of K wires, thick wires, and that corrects the heel varus as well as the tuberosity inclination and gives you space for the subtalar joint reduction later on. So that this maneuver will align the tuberosity to the medial, to the sustentacular fragment. The medial wall will be reduced in the axial view. So this all is being done. So I'm coming into the fracture. So it's important to look here and see that you are actually engaging the sustentacular fragment in the axial view, and you're not exiting the fracture there. If you remove the lateral wall blood, you will be able to see if you are doing that. So once you have fixed that fragment, you can remove your Steinmann pin, or you can advance the same Steinmann pin as a further hold into your sustentacular fragment. So this is now reduced to the medial wall, and the next step will be to lift up your lateral fragment, the lateral depressed fragment. So this was a fragment which was lying like this. So now you have made the space. So what you do is to take a blunt instrument. Anything? Hello? So you take a periosteum or something and you lift up this fragment and align it with the lateral edge of the talus. There are a couple of guides there. One is the lateral edge of the talus. The other is the Bohler angle, because if there is no comminution in the Bohler angle, this area, so you can align this fragment here, and you will have your guide to reduction of how much you have to lift. Otherwise, you see the articular surface of the articular part of the undersurface of the talus edge and the anterior edge of the articular surface have to match. Generally, the mistake is to lift less and not more. So most of the times we end up somewhere here, which is not good. So you have to lift it up all the way back, and then provisionally fix it with a K wire. So this K wire then starts about 5 millimeter planter to the articular surface, and the direction is about 10 degrees. So right now I'm absolutely vertical, so I will tilt 10 to 15 degrees towards the heel, my drill goes, and about 10 degrees down, which is the inclination of the sustentaculum. Now this step has to be monitored in an axial view. In an axial view, that you are going into the sustentaculum tali and not under it. Under it is the FHL tendon and the neurovascular structure, which if you drill on that area, you will injure those structures. So this fixes the lateral wall, and then you take an axial view, take a broaden view. If you really want to look at the joint surface, there are a couple of options. If you just do a heel inversion at this stage, most of the times you are not able to look at the fracture line. So if you have a small distractor, the Hintermann distractor which I showed in the video, you can put one pin in the tuberosity and one pin in the talus and distract it and see that the joint surface has been reduced well. The other way is obviously to do a C-arm, broadens views and lateral views and axial view. All three will show you the surface of the joint, and you can see that there is no step. If you are good at doing broadens view, you can very well see the fracture line and the joint surfaces. So the tuberosity reduced, medial wall reduced, the lateral facet has been lifted up and reduced. At this stage, you need to look at the calcaneocubar joint, and if there are any fragments or steps there and you need to put additional K-wires to stabilize them, you will do that. You can also, if your tuberosity has more fragments, you can also fix the tuberosity to the anterior process by a separate wire before depositing back your lateral wall blowout, and then finally the plate goes in. So that is the lateral wall blowout, which has been now put back. You can actually crush the lateral wall blowout and put it in the void which has been left by lifting off of the lateral facet. So there's a big void. It does not require a bone grafting, but I prefer to crush the lateral wall and put it in the void. And the next step is simple, to put the plate. So this plate is malleable. The anterior part of the plate is meant for the cuboid, and this angle arch is meant for sustentacular screws below the thalamic screws holding the lateral facet to the medial calcaneal, medial sustentacular fragments. So we have a locking sleeve. So once you put that plate, you'll see how malleable that is. Generally, when you put that plate, I first put a 3.5 cortical screw, so we have a 2.5 drill bit, into the tuberosity. The first screw that I put is into the tuberosity to stabilize the plate. Now, this wire is stabilizing the lateral facet, fixing it temporarily. You can choose to put one screw alongside the wire just to hold provisionally, just to hold rigidly the sustentacular fragment from this side. Can you stabilize the plate for me? Thank you. So first screw is into the tuberosity. इधर मेरे हाथ में दे दो, पता नहीं चलेगा. So generally I use the woodpecker technique. The woodpecker technique is going like this, touching the bone every time you go forward, and then you use your depth gauze and a proper 3.5 cortical screw. So that's 30. Generally, I will put a screw out of the plate in the direction of this wire that we just showed. So that gives you more confidence that your lateral facet has been stabilized and will not move while the time you're fixing with the plate. And sometimes it's possible to put another screw, the sustentacular screw, also through the plate, which gives you a better hold because the screw head does not sink into the bone. If it is into the plate, it gives you a better purchase. So that stabilizes your plate onto the bone. Now this plate it is possible to, one more locking sleeve. You have one more locking sleeve. So you see how malleable this plate is. It is possible to mold this plate. If parts of this plate are lifted, off from the bone, you can use your locking towers. Can we have something to tighten this? You can tighten the locking towers with a mosquito. With a mosquito, tighten them fully, and you can use these towers as benders of the plate. So it is possible now. If I do this, you see the plate has gone down here. So this plate is fairly malleable, and each part can be individually bent, changing the locations of the locking towers wherever you want to bend them. This is a tentacular screw, 2.5 drill bit. So close to the wire, there is a hole which can very easily take a tentacular screw there. That is an ideal location about 5 to 10 millimeter below the level of the joint, and the direction, obviously put your drill bit perpendicular and then bend your drill bit posteriorly a bit and plantarward about 10 to 15 degrees. And every time you do this, you do a woodpecker technique, in, out, in, out, in, out, and monitor this drill progress into the C-arm. In the C-arm, if you've gone about 1 centimeter, you can take an axial and see the direction in which you are going, rather than going all the way and then taking a shot. So it is, you start the drill bit and you take a shot. This 35. And then obviously you will put one cortical screw in the anterior process. One cortical screw in the anterior process, and then one locking screw in the tuberosity, one locking screw into the anterior process, and maybe one into the center of the body. So 2 screws per fragment should be enough. And again, this screw progress is monitored in the axial view. Obviously, if your drill has gone in the right direction, the screw will follow the path. So I'm not going to show the other screw. I think it's simple. One screw here in the anterior process, and then I'll use the locking tower into the tuberosity here, and one screw maybe into the body here, and one screw into the anterior process. Now many times you have to cut off the apex, the arch of this plate. The last screw needs to be cut off, or you can use your locking tower and bend this, this screw hole onto the calcaneus posterior side, and you can put one screw almost parallel to the subtalar joint, exiting into the plantar side. If you have a fragment on the plantar side which you want to hold, you can use this screw hole to do that job. And then in the end, obviously, give a good wash and do a very good closure. Algova donatis. I generally prefer to put a drain in all calcaneal fractures. Some people may disagree, but I've seen a lot of difference when you do not put a drain versus when you put a drain. A negative pressure, a Romovac. So any questions? Sorry? Minivac.